All right. Hi, everyone. Good afternoon, and welcome to part two of the Hepatitis B Immunization in Pennsylvania webinar series. For those of you who weren't able to make it last time or might not know me, my name is Michaela Jackson. I am the Program Director of Prevention Policy at the Hepatitis B Foundation, and we're partnering with the Pennsylvania Department of Health here to do this awesome presentation with two amazing providers about implementing hepatitis B in Pennsylvania in your practices. So I'll just kick it off with a quick overview of a couple things before turning it over to our amazing presenters. So first, I'd like to highlight that we are recording this webinar. So everybody who registered will receive last week's presentations as well as this week's presentations after the webinar ends. And we're also going to put together and compile the questions that we had, since a lot of people had a lot of really good questions, so that you can all see the responses. For participation in this webinar, though, everybody is automatically on mute, but we will have a Q&A at the end where you can raise your hand and come off mute to speak, or feel free to drop a question in the chat or Q&A box below, and we can answer as we go or again at the end. So just to get started with a little overview of what we discussed last time, today's presentations will be focused on the implementation of the universal recommendations. Last week's presentation was more on the epidemiology of hepatitis B and specifically what that looks like in Pennsylvania. So hepatitis B is the world's leading cause of liver cancer. Almost 80% of all liver cancer cases in the world are attributed to hepatitis B. About 70% of adults in the US have not been fully vaccinated for hepatitis B, which means they haven't completed their series, and series completion is really important for protection. Hepatitis B, we talked about how infectious it is and why prevention is so important. And one of those reasons is that it can survive on surfaces for up to 7 days. So a really long time. And a lot of people are not properly cleaning surfaces as we would need to get rid of the virus. So just a reminder that vaccination and screening really, really are super important for a virus that is this infectious. In the United States specifically, Asian Americans, Pacific Islanders, and African immigrant communities are disproportionately impacted by hepatitis B. So we often see higher rates of chronic Hep B in these communities. And also, one of the most important things I think to highlight, especially in light of the universal recommendations, is that anybody can really get the hepatitis B virus at some point in their life. There might be a risk factor. One thing a lot of people are often shocked to learn is that sometimes it's as simple as having a health condition like diabetes or like another comorbidity that can put you at additional risk for hepatitis B. So prevention is essential. And we also had really great presentations by the state health department as well that talked about what hepatitis B looks like here in PA. So I just put a few highlights from the presentation on the screen. As I mentioned, you will be getting the recording and the slides as well. So you will be able to go through and see all the specific charts and numbers that the Pennsylvania Health Department presented. But essentially, some things to highlight is that we are seeing hepatitis B in primarily middle-aged males in Pennsylvania. Acute and chronic, the populations impacted do differ, and Pennsylvania does experience lower hepatitis B rates compared to national rates over the past few years. And the Pennsylvania Health Department will also partner with organizations and health systems to help improve hepatitis B vaccination rates. And so I dropped their email in this slide, and you can contact that email for additional questions around adult immunization programming and services that they might provide. And so, with that, I will share that we have two amazing presenters today, Dr. Kami Graham and Dr. Myra Rutland, who will go ahead and share a little bit of how we can work on implementing universal hepatitis B vaccination into our practices and how we can speak with other providers and the public about hepatitis B vaccination and why they should be getting vaccinated. And so, with that, I am happy to turn it over to our first presenter, Dr. Graham.
All right, let's go to the next slide. Okay, so I'm mostly going to be talking about hepatitis B vaccination from the perspective of my role at a large academic medical center, probably like some of you are in. But I'm also medical director at a community based organization that does syringe access, STI testing and treatment. And I might mention some of the differences in implementing vaccination in a non-medical setting like that. All right, so let's go to the next slide. All right, I don't have any disclosures for hepatitis B. Next slide. All right, so we're going to talk about vaccination. We're going to talk about screening because you kind of have to talk about screening when you talk about vaccination and how to marry those two sets of data, and then some practical implementation suggestions. So the first thing I wanted to do, you all have seen sort of a slide like this, but I wanted to overlay my own personal story around hepatitis B and from the perspective of vaccination, just to give it a little bit of context. I actually have a family member who is a healthcare worker who acquired hepatitis B prior to the advent of vaccinations, and so the issue of being able to prevent this highly infectious, serious infection is a very personal mission for me, as well as one that I care about a lot medically as a physician. And so there was a period of time where a lot of people acquired hepatitis B through many different sources because we didn't have vaccination. I actually got my vaccine in 1991 when I went to medical school, and I was super excited about it. And that happened to also be the year that we first started universal infant vaccinations. I will say the 90s were a little sketchy in terms of uniform implementation of childhood vaccination. Universal Infant came about in 91. There was this adolescent catch up, although I think we recognized there were a lot of people that fell through the cracks that started in the mid 90s. My son was actually born in 1997, and I was asked if I wanted to have him get birth dose hepatitis B vaccine. I'm like, oh my God, of course I want him to get a birth dose. I don't think I fully appreciated universal birth dose vaccination didn't occur in the United States until 2018. That might have been why they looked at me so funny. But universal birth dose is actually incredibly important. There's some data that suggests that if you you vaccinate these babies at birth, they actually end up with pretty durable long-term response to the vaccine compared to waiting until they're a little bit older. And then, of course, in 2022, the CDC came out, or actually an ACIP came out with universal recommendations for adults age 19 to 59. And I want to frame this as sort of like the adolescent catch up we did in 1995 for people who were old enough that they didn't get the baby vaccine. We now have vaccinated most people that were born in the United States that are underage, maybe 25, 27, somewhere around there. I think those kids that were like in that 90s time period, they're now like 25 to 30. That was a little bit of a sketchy time. I think we missed some people then. But I want you to think of this adult recommendation as like the adult catch up to the younger people that we've. Okay, so think of it as an adult catch up program. Next slide. All right. So the first thing I want to emphasize, and you've seen this before, is this vaccine works. Sometimes we get a little bit of worry about how well certain vaccines work, but when you implement universal vaccination, like in our 0 to 19-year-olds that we have in the United States, you have almost no hepatitis B infection. This is a phenomenal vaccine. And unlike some vaccines that you have to get like every year, this is a vaccine that you basically go through one series. In rare occasions, you need to go through more than one series, mostly one series, and then you're done for the rest of your life. And so, again, thinking about all the other vaccines and maybe the pros and cons of all of them, this is a pretty straightforward and highly effective vaccine. And as you saw in your state in Pennsylvania, it's the older individuals that miss that catch-up period that are the ones that are vulnerable for getting acute hepatitis B now. Next slide. Okay, and we're doing an okay job. I mean, the children should be 100%, but we know even with like measles and things, we're not at 100%. We're pretty good with the young people. Where we really start falling off with is with older individuals and with people greater than 50. It's only 19%. Remember, Michaela just said there are health conditions that increase the risk of hepatitis B acquisition. Some of these health conditions are more prevalent in people age 50 and older, and we've got a huge gap between what's happening right now and what's needed. And the last line is something that I really think about: chronic liver disease. All of these individuals for years have been recommended to have hepatitis B vaccination. And in this last survey, it was only 33%. So this just shows even people with very, very high risk for severe consequences if they were to acquire hepatitis B are not being effectively prevented, vaccinated. Next slide. Okay, so we've got this recommendation that all individuals 19 to 59 that have not been previously vaccinated, haven't gone through a full vaccine series, need to be vaccinated. The age 60 and older, I think, is a little bit unfortunate, and I think there's some historical reasons why ACIP did do this, but it's a little bit more complicated in that you're supposed to look for people with risk factors. However, anyone without risk factors may receive the vaccine, and they really, in this guidance, recommend that everybody, including all of those individuals age 60 and older, should have a dialogue about vaccination and an appropriate sort of risk benefit conversation. Next slide. So I'm going to be focused on using the electronic health record as a way to facilitate implementation of hepatitis B vaccination in large healthcare systems, because that's really where a lot of us work. It's where a lot of people get care some way or the other. And it's really where we've got the big EHR systems that we can work with. But as I said, I work in a program that does syringe access, sexual health, and we've been able to successfully integrate hepatitis B vaccination in those programs. And I will just tell you, it's universal. So we don't need big fancy EHR because we basically just vaccinate everybody. And I think another area where there's big missed opportunities is in our corrections facilities. But we're going to focus today mostly on big healthcare systems. Go ahead. So I've done a lot of medical decision support over my 25 years in this kind of practice, and with a good number of sort of electronic medical prompt implementation. I don't think I've ever run into the degree of frustration and resistance that I have with implementing hepatitis B vaccination, especially in conjunction with screening. And this group of people that you see here, including Michaela, who you just heard from, we were all experiencing the same sort of conversations with people who are trying to understand how to effectively implement these recommendations. And we ended up deciding the best thing to do was just to write a paper. about it. I suggest that you look at this paper if this is something that you're interested in, because we loaded it with practical solutions that are geared both to you as the champion of your institution. You're the one that's going to go in and say, we need to, do this more systematically. Maybe there's your approval committee, that has to understand the rationale, and this is going to be too much, prompt fatigue burden and all of that stuff. And then your IT team that needs to implement a program that's effective and doesn't frustrate the clinicians. And so that was the point of this. And you're going to see, I'm going to walk you through some elements of this paper. Go ahead. Okay, so this is just a little flow diagram, and I've cut out the stuff in the middle, so don't worry about it right now, because you can do a vaccination program without implementing a screening program for hepatitis B. I think this is really important because one thing that gets people hung up is, how can I do screening and vaccination? And just, I'm going to recommend right now, always start with a vaccination program. Just get the vaccine program in place, make sure it works, and then step back and think about how to improve your screening program. I'm commenting here on, do they have a history of prior vaccination? That means documented receipt of a full series of whatever the full series is, defined by the brand, the population, and the dose. We don't take people at their word if they say, oh, yeah, I got MMR or I got pneumococcal or whatever it is. You want documentation. And so if they don't have documentation, go ahead and start the vaccine series. Okay, so if they're 19 to 59, you look, do you have prior vaccination? Maybe they've been in your system for a while. Can we go back? Can we go? Yeah, thanks. You don't need to vaccinate, and if they don't have documentation, vaccinate. If they want to say, like, let me go home and look for it, and then they come back and they still haven't found it, please just go ahead and start vaccinating. For age 60, it's basically, do they have risk factors? If no, talk to them about vaccination. If yes, go ahead and start vaccination. Now the next slide. There's a couple of different ways that you can handle these people that are 60 and older. One is to try to really figure out ways to identify risk factors. I will tell you that's failed with HIV. It's failed with hepatitis C. We do terribly identifying risk factors, but maybe in your system you want to try to identify risk factors. You still have this caveat that you're supposed to have a conversation with every person over the age 60 and older. So you send letters to everybody, and then informing of the vaccine. Or you can just add a hepatitis B vaccine prompt to everybody, including those people over age 60, and just keeping in mind that those over 60, part of the prompt is to prompt you to have that conversation with individuals. Keep in mind that between the Affordable Care Act and the Inflation Reduction Act, these vaccinations are covered for everybody. Next slide. Okay, so I'm going to show you an example of what this looks like actually in a historic EMR, EHR that we had that we're trying to replicate in Epic right now. But basically, what you want to be able to do is identify the brand of vaccine, because different brands have different dosing. And I will tell you, I know this from painful experience, because we initially just had something like hepatitis B vaccine, and then it was kind of a mess when you were trying to figure out which vaccine they got and how much and everything. So just, you need to list the brand. And then you may have selection of a preferred brand. That's going to include P&T committees, contracting, other entities in your institution. You want to identify the indicated populations. Some vaccines are adult only. Some have different dosing for something like, say, hemodialysis. You want to pre-populate that vaccine schedule when they select the vaccine. Then you want all of the subsequent vaccinations with the appropriate doses added to that person's dashboard. So if they come in for some other reason, another provider can see, oh yeah, you're due for your second or third, whatever vaccine. You can go ahead and schedule future appointments. Typically those are nursing appointments. Send reminders. These all can be programmed into your EHR, and they're all described in the paper I just mentioned. And then provide decision support tables and frequently asked questions. That's going to save you a lot of time and energy and effort if people do run into commonly confusing things. And we have a couple of examples I'm going to show you. Next slide. Okay, so here's an example in an electronic medical system where you've got a bunch of different vaccines that are potentially available with why you might pick them. Are they a child? Are they someone with end-stage renal disease? I will tell you, we've pre-selected Hepatitis B. I'm just going to mention because it is what we did in our institution, a little bit about why we did that. But you want to give real clear guidance about populations, dosing, and then build in your time interval of when they're due in the back end of the system, so those prompts just come up and people don't have to worry about how to figure that out. Next slide. All right. So I'm going to mention a little bit about some of the different vaccines. The older three vaccine series, typically three vaccine series, had a good number of conditions where people were non-responders to the vaccine. One of them was older individuals. And I will tell you, it was only recently that I realized that the definition of old was over 40. I kind of take personal affront to this. And then the other one that I find particularly interesting as someone trained in immunology is there's certain HLA haplotypes that are associated with complete non-responsiveness. These are people you can turn into a pincushion. They will not respond to the vaccine. So go to the next slide. So you give whatever vaccine you have. If you have access to the like Engerix-B or Convax-B, use them. I just want to just mention a couple of things about the vaccine we decided to use as our default vaccine, Hepatitis B, and one of the reasons was this was the first time we saw a vaccine that appeared to overcome that probably genetic barrier that we saw with the older vaccine. So, in this particular study, in those younger people, 18 to 29, and about a 94% response rate with the older vaccine. That's very typical. Lots of studies have shown about 5% of people don't respond. This is the first time we saw 100% of these young people responding with the newer vaccine. And then on the other end of the age spectrum, individuals 60 to 70 typically not responding well to the older vaccine, having a 91.6% response rate, which is pretty reasonable with the newer vaccine. A new study has just come out showing that Hepatitis B has remarkable response when you give 3 vaccines to people who are living with HIV. That just came out this month in JAMA. And then there's another study that looked at healthcare workers who were non-responders to the older vaccine responding to this newer vaccine. So just some background for this one, but again, whatever you have, go ahead and give that vaccine. Okay, next slide. All right, and so the problem with hepatitis B is even if you don't have a screening program, you will have hepatitis B serology data in the system that indicates that this person was previously exposed to hepatitis B or perhaps had previous vaccination and it just wasn't recorded. So if they have surface antigen, core antibody, surface antibody, E antibody antigen, DNA, then they've been either previously vaccinated or previously exposed and they don't need to be vaccinated. And so when you think about how you're going to integrate it, you're going to have to talk to your IT people about identifying these data and weaving them into your algorithm. And go to the next slide. And this is because your providers are going to want to see a prompt for everybody who meets criteria. And if they discover somebody who they think needs the vaccine who hasn't been prompted, then they get anxious that every single person doesn't have a prompt. They maybe have been missed. But it's equally critical to not prompt for vaccination in people who don't meet criteria, because then they don't trust any of the prompts. And this is the trick that makes providers crazy, and that has literally made entire large healthcare systems have to pull the prompt to reprogram it, so that you didn't make the first two bullet mistakes. You may want to do universal screening for hepatitis B. Unfortunately, risk-based screening is the only one that is USPSTF grade B recommended right now, which means covered by insurance. That is a grade B. You do need to be doing risk-based. The universal is not yet supported by USPSTF. Hopefully that will happen soon. But until then, you've got a financial challenge with universal screening. We mentioned that you need to account for the existing serology. You want to provide additional support, and I'm going to reiterate: don't try to implement screening and vaccination simultaneously. Next slide. Okay, I'm running out of time, so I'm just going to say you'll have these slides as a reference. Put together a screening panel. It decreases ordering errors. Next slide. And here's an example of something that really can be helpful for your providers in your system. And it's just showing them how to interpret serologies. Maybe it's not a screening program. They're already existing in the system, but they want to know, I'm seeing these serologies. What does this mean in terms of vaccination? And if somebody has negative serologies for all of the screening panel that's recommended by the CDC and actually ACOG, then you vaccinate them. If they're isolated surface antigen, it's almost always a false positive. Usually they got a vaccine and they got the blood drawn, which you're not supposed to do. You're going to repeat that screening panel before you give the next vaccine. Okay, next slide. And then all of the other serology patterns do not need vaccination, with the possible exception of isolated core antibody. And from what I can tell from talking to a lot of people in a lot of healthcare systems, the simplest thing to do for that case is to ask everyone who's isolated core antibody to be referred to a hepatitis B specialist for evaluation. And I will tell you, this is going to represent less than 3% of the people who are being screened. And it's a little bit complicated, and it's just easier to say that's a group of people. It's a small group. It'll be 2 to 3 out of 100 that you'll just send them to a specialist to talk about it. Next slide. I think I'm coming towards the end here. Okay, I'm going to skip these questions. These are in the paper. So go ahead and click ahead. Yeah, go ahead and click ahead. These are in the paper. Okay, and then finally, we all have to work together to eliminate hepatitis B. And I just plug every time I get a chance to talk to folks like you all, that if you are developing programming to support vaccination with or without screening, please share it with fellow organizations in your state, nationwide. And consider working with Hepatitis B Foundation to share it with the EHR companies. If you do happen to have non-risk-based hepatitis B screening data for some reason, please share it with USPSTF and CMS. It's the only way we're going to, possibly get a recommendation for universal screening, which, again, risk-based screening typically does not work. And please publish your data so that other people can learn from your best practices. Okay, I'm done.
Thank you so much, Dr. Graham. And with that, I'll turn it over to Dr. Rutland.
Thank you so much, Dr. Graham. That was awesome. I love listening to what you shared, and I will actually be encouraging my organization to review your paper, and maybe we can get a little more muscle behind ensuring everyone screens. So first of all, my name is Dr. Myra Rutland. I'm the Senior Clinical Director and Director of Infectious Disease at Spectrum Health Services, located in Philadelphia, Pennsylvania. I want to thank the Hep B Foundation and PA Department of Public Health for inviting me to participate in this awesome opportunity to talk about hepatitis B and the role of the primary care provider. Next slide. Hepatitis B is a So many of the things I'm going to share are repetitive of what Dr. Graham just shared. But I think it bears repeating because once you kind of have some things drilled into your memory, it becomes rote. And that's what we need here to eliminate the continuance of Hep B. So here we are. Can you all hear me? Should I speak a little louder? Someone let me know if I need to speak a little bit louder. So our objectives today, why hepatitis B? Primary care means prevention. So we'll talk more about that role. We're going to talk about screening, immunization, treatment, and we'll summarize the decline of a very, very preventable virus. All right. Next slide. All right, so why hepatitis B? Primary care is not just the provider who sends patients elsewhere when they need a specialist to take care of something that is not in their realm. It is important that primary care focuses on prevention. That's what we're here for. So I like to think of primary care providers as the key personnel to collaborate with patients and provide them education and information. And in this case, as far as Hep B is concerned, we need to educate them in understanding that it is highly transmissible, 100 times more infectious than HIV. I think when people hear about HIV, they think of that as really, oh my God, the moniker, the thing that scares people. But I want to share with others that Hep B is a lot more problematic. So transmission of hepatitis B can be avoided simply with immunization. There are occupational hazards associated with Hep B, and primarily we think about healthcare workers who should be offered the Hep B immunization, but there are other hazards to hepatitis B, other occupations. If you work in a nail salon, if you are a hairdresser, and you're working with sharps and clippers, it could be something that you're exposed to there if you're a tattoo artist, right? It's preventable with immunization. It's a safe, efficacious vaccine. And the other role I think that primary care providers should include themselves in is to normalize. I put screening here, but I agree with Dr. Cami. We really should put more emphasis on the fact that we need to vaccinate. But if we can normalize, yep, I'll turn off my camera. If we can normalize screening and immunization, that would be helpful. Okay, let me know if that improves things. Next slide. All right, so I focused on the United States Preventative Services Task Force as one of the recommending bodies for screening, hepatitis B. Okay, I'm not sure if I should log out and try to log back in. I'm a little afraid to do that. You let me know what you'd like me to do. I'll continue to talk until I get some guidance from you, okay? All right. I apologize if my reception is spotty, not sure what's going on. But the United States Preventative Services Task Force recommends screening for hepatitis B infection in adolescents and adults at risk, and it recommends immunization. But the other thing is, there are other bodies that strongly recommend, such as the Centers for Disease Control. Apologies for the issues, guys. I don't know if I have a set of headphones that are suitable for this. I'm going to continue to talk until I try to figure something else out. All right. I can always go back and re-record it and then send you guys a recording of it if that's helpful. Maybe that's the solution at a later date. I could do that. All right. But the Centers for Disease Control recommends, the ACIP makes strong recommendations. OSHA Our occupational hazards makes a strong recommendation. And of course, Hepatitis B Foundation makes recommendations. And that little QR code there is for you to see what those recommendations are and where they come from. Next slide. Okay, so there are some grade B, the United States Preventive Services Task Force offers a grade B recommendation, and these are some risks to consider. If you have a patient who is born from another country, because what we know about hepatitis B is that it is endemic in most parts of the world. In particular, Asian countries, Africa, Eastern Europe, South America, Australia, all of those countries have a high prevalence of hepatitis B. If you have a patient who's injected drugs in the past or presently injecting drugs, that is problematic. Patients who are men who have sex with men, living with HIV, if they've had hepatitis C in the past, if they're using opiates, rather, if they're using opiates, whether it's inhaled or injected, that's a problem. If you're living with someone with known hepatitis B, there is a strong recommendation that those persons become vaccinated. And that's where I want to point out, if you're over the age of 60 and you're living with someone who has hepatitis B, because of the high prevalence of transmission and the high infectious nature of the virus, it is strongly recommended that everyone in the household get vaccinated. If a patient has multiple sex partners, and of course, being incarcerated, they don't do a good job of vaccinating persons who have been incarcerated or presently incarcerated. I put in green there, persons born to the US prior to the immunization schedule. I think Dr. Graham did a great job of going over that. So I won't reiterate that, but it is something that we need to consider in terms of ensuring opportunities where we may have missed immunization. Next slide. So here I'm just offering what the actual recommendation definitions are as indicated by the United States Preventative Services Task Force. And it is here a grade B recommendation. So it recommends that there is a high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. So regardless, the guidance is to offer or to provide this service. Next slide. Next slide, please. Okay, and again, just another opportunity for you to review the definition of what moderate is. I won't belabor the point, but again, I don't want someone to think of the alphabetic assignment to the recommendation and think of it as less important. That's really the reason why I just included the definition, because the evidence is sufficient to determine that the risk of not vaccinating is greater than than vaccinating. It's limited in generalizability of findings to routine primary care practice, lack of coherence in the chain of evidence. As more evidence becomes available, the magnitude or direction of the observed effect could change. And so that's something I want to kind of hang my head on for a minute. These recommendations are not written in stone. As there's more science that's developed regarding hepatitis B, that recommendation could indeed become stronger. Next slide. And again, here is another definition, the high level of certainty. And I'll just give you a moment to read this for yourself, as it indicates that there are studies that support the conclusions that come about for the recommendations. Next slide. Okay, so, we didn't really go over a lot of the lab work. And I think, as we've kind of mentioned, this is the part that kind of gives providers the EBGBs, right? But if you understand the reasons why we need to do the 3-part surveillance, I think that this gives you a good picture in your mind. At least for me, I found it important to understand why I need to do 3. Most of the time, I come across providers who will simply do a screen and not do the surface antibody as well as the core. They're not necessarily looking at whether or not there's an actual virus, but if you understand what the core represents, right? You're actually looking at the core being that the virus has gotten into the DNA of the person that it's infecting. And once it's in the DNA, it's not going to come out. We're looking also at the surface antibody where either the patient has been immunized and they're fully protected, or they've been exposed and they've developed their own immunity, and whether or not there is an actual virus that is in a place and given opportunity for it to replicate. Next slide, please. Okay, so I want to spend a few minutes on the serology when we order the 3-part vaccine. And I'll just take a few moments here. If you're doing the 3-part series, you're going to do the surface antigen, the surface antibody, the total core, and in this column here, obviously, is the clinical significance. If you're doing the 3-part series and the lab work comes back, obviously, as a positive surface antigen, as well as a positive core, if you think back to that slide previously, and you could see that the virus is in the DNA, that means that this person has an acute infection. If, and you're looking at the IgM, right? If you do the serology and you have the surface antigen and it's an IgG that's in the core, that's a chronic infection, right? So there's some other nuances with this that may or may not be important, but the key is if these things come back, the antigen and the core, you have an active infection. You have an infection, okay? Whether or not it's active or replicating will be for a specialist to look at, or someone who's used to doing this to look at, but this is why it's important to do both. If you only did this, you may not know whether or not it's acute or chronic, and you may want to do more. You'll need more information. If you do the 3 parts and it comes back surface antibody positive and the positive core, it may be that they've resolved an infection and they're immune, or perhaps they've had a reactivated infection. You need to know a little bit more about the patient's history. If you have a positive surface antibody, a negative antigen, and a negative core, this person's been fully immunized and they've mounted a response. Here's where we're hanging our hats today, because not only do we want to screen for it, we want to immunize people. We want to protect those 70% of US citizens who have not ever been vaccinated for Hep B. So if it's a negative surface antigen, surface antibody, and a negative core, you're susceptible and they need to be vaccinated. So if a provider just does a surface antigen, it doesn't give me much information. This is why doing the 3 parts is really important. It doesn't tell me, well, they don't have it, but have they ever been exposed to it? Do they need to be vaccinated? That's what these other 2 pieces are going to tell you. So that's why it's really important to get this information. If you have a negative antigen, a negative surface antibody, and a positive core, that becomes a little bit more tricky. And it could possibly be that maybe this person was maybe newly infected. Has it been resolved? Is it a cold infection? Is it a false positive? It just produces more questions. So, there's a little more nuance to further investigating that and additional testing that may come about. Next slide. And I just want to say, if there's anything with that slide that I did not fully discuss or, may have been erroneous in discussing, Dr. Kami, I will fully invite you to circle back and help, and further explain that. All right. So the Centers for Disease Control recommend hepatitis B for all persons. We're, however, all infants, unvaccinated children, under the age of 19. And however, our focus is on adults, 19 and 59, and adults age 60 and older. There should certainly be a discussion. And again, I want to emphasize that if that person who's 60 or older is living in a household with someone who has hepatitis B, they absolutely should be vaccinated to protect them, because the likelihood is, based on their age, unless they are doing a type of occupation that requires them to have been vaccinated, the likelihood is that they're not protected. And the following groups may receive Hep B vaccination. Obviously, if you have that discussion and the person feels it's important for them to be protected, that they will get vaccinated. Next slide. All right. So I believe that we looked at some of these in the previous presentation, but I'm digging a little bit deeper, because sometimes the challenge that clinics have, and I know for my clinic in particular, we have to be savvy with the finances that we have to provide private vaccines, and we certainly have to be judicious and good stewards of any vaccines that we get from the state or the city. And so, in terms of reimbursement, it may be prohibitive for certain clinics to have a dose of a vaccine that's $134. Even though it's 2 doses, it's still going to amount to more money to give these 2 doses than these. So, from a financial perspective, you may not be surprised if you get some pushback from your administrators from using Heplisaf, which is really just for adults, but it is a very good vaccine. It's 95% efficacious in just 1 dose the first month. And because it's 2 doses, you're more likely to complete the vaccine series. And if you have to rely on the 3 doses that's required for Injurix and or Recombavax. These are also effective vaccines. The primary takeaway is, whatever you have, use it, and do your best to ensure that if the patient has to come back for a second dose or a third dose, that you have some type of system in place to make sure that the patient gets their reminder and that the staff helps to get the patient back in the clinic to get their immunization. Next slide. So here are some of my concerns about Hep B and drug-induced reactivation. So if you have a patient who's seen, and I think the reason why I put this in here is because if we don't do the 3-part series in terms of screening, and you don't know whether or not they've previously been exposed to Hep B and they have a positive core, or they have an active or chronic infection, and you start them on a tenofovir-based product, tenofovir is going to help quell the quell Hep B. It also prevents HIV. But if you decide to take the person off of it and they've had exposure to Hep B in the past, you could actually trigger fulminant liver disease. And what some providers don't know, that same potential exists for these other medications, which are used very commonly in primary care or specialty care. If you have a person who's an asthmatic or poorly controlled asthma or some type of airway reactivity, we use prednisone like we use alcohol pads. We prescribe prednisone pretty regularly, but giving the giving the dose of prednisone could actually cause somebody who has a positive core to reactivate hepatitis B. So I don't know that people realize this. And so that's why it's really important to ensure that you have all three parts and that you surveil for that person's exposure status. There are JAK inhibitors that are now being used to treat psoriasis, to treat other rheumatologic disorders. Dermatology is using them, is treating alopecia areata. And I would hope that those specialists would know or actually look for the Hep B history for a patient, whether or not they've been fully immunized and or whether or not they have a positive core or a chronic infection, because doing so, again, could trigger liver failure. Oncologic providers are providing chemotherapeutic agents would definitely benefit from having that information on hand prior to prescribing and treating any existing cancers. Next slide, please. Okay, so what's the summary? We have just a few minutes left here. So obviously there's a decline in the amount of immunizations of preventable diseases. It seems like since COVID, people are a lot more vaccine weary. They're not interested in getting immunized. And certainly for whatever reason, whatever is happening in our social sphere, people are a lot less trustworthy of immunizations. But the science is there. This vaccine has been around for many years. It is effective in preventing hepatitis B, therefore preventing cancer, liver cancer, because hepatitis B is the number one reason for cirrhosis of the liver and or hepatocellular carcinoma. And on this side here, I want to emphasize what primary care can do, right? We have to raise our voices. We have to combat what others are listening to. People are going to social media and other platforms for information that may or may not be correct and may or may not have full data. It may be partly true, but it may not be fully true, which means that they're not going to be able to make the right decision because they don't have what they need in order to do so. We need to speak to patients using non-clinical terms with analogies that they can identify with. Our patients want to be heard and they want an opportunity for discourse. And this can be hard because, when you have a 15-minute appointment to take care of multiple issues, you may not have time just to discuss vaccine hesitancy, especially for something like hepatitis B, which they may or may not think that they're at risk for. And finally, I just want to emphasize to be respectful. I've talked to patients who've not had not just the Hep B vaccine in the past, but other vaccines. And when I give them opportunity to voice their concerns or to ask questions, they'll express that they, would have gone through with it, but the provider was kind of in and out of the room in 5 minutes and didn't really give them opportunity to explore their concerns. And, that's just unfortunate. I like to use a website called Voices for Vaccines. They have great data and stories that patients can relate to. It is a site that speaks to patients from the patient perspective and a little less from the provider perspective. So I think it's one of those awesome ones. I like to also use immunize.org And I also will still refer patients to the Centers for Disease Control. Next slide. And that's it. Thank you very much.
Thank you so much, Dr. Retland. And I think we have a couple minutes for Cami and Myra to answer a couple questions. So I can turn that over to Shri. There's a couple questions in the Q&A box.
Yeah, thanks, Michaela, and thanks both of you for a very elaborating presentation. It was really nice to hear what you've been doing, and it was very detailed. And we do have a few questions in the chat here. So Gail is asking, and either of you can answer this question. If providing an PEP for HIV exposure, are you saying you should wait until Hep B SAB results?
No, I wouldn't wait. If you're talking about prevention for HIV?
Yes.
Absolutely not. Because you want to prevent HIV, and the risk of acquiring HIV outweighs the benefit of waiting, right? So
Yeah.
you can do all those labs all at the same time, because if you're starting PrEP, you're going to get a viral load. And while I'm at it, as a part of my typical routine, I get all of that. I will get my HIV exposure labs. I will get viral load I will get all three parts of the hepatitis series in addition to STIs, and then I kind of know from there.
Yeah, at Rise we do on-demand same-day prep, and you can't wait for labs. But just like you do, we do get baseline labs at the same time, and then if somebody is surface antigen positive, that is a different conversation. You need to bring them back, and you need to say you're on prep, but this prep is also hepatitis B treatment. And now we've got to follow you for your hepatitis B treatment like you would anybody else who's just been started on hepatitis B treatment. And so they need to understand the complexity. I've had some young people who wouldn't necessarily meet criteria for hepatitis B treatment decide that they would rather take a non-hepatitis B treatment prep regimen. There's others that are like, oh, if I get undetectable with my hepatitis B viral load, does that decreases my risk of transmission? It's kind of like a U equals U type idea, and I personally really believe in that. And so but this is a counseling situation that doesn't happen very often. So you just go ahead and start people on PrEP, and then there's a small number of people you may need to have a more complicated conversation with.
Thank you, and thanks for providing that tips on how to counsel the patients, and telling them about how getting protected is more important than waiting for the lab results to come. Are there any resources online that providers can refer to as far as counseling tips are concerned? Like, is there any website or maybe journal article that you follow?
I use the same immunize.org. Hepatitis B Foundation has some great resources.
Mm-hmm.
CDC, I actually just referred to CDC, so I was looking up a recent, they still have good material on CDC. So I think those are good resources. Exactly. Hey, Ashwin, can I add one thing from what Dr. Mara just was talking about? So in terms of the pricing of the vaccines, I also, when we were discussing what the preferred vaccine would be at our institution, I actually did sort of like a little cost effectiveness analysis, looking at cost per episode of seroprotection, because you're not paying for the vaccine, you're paying for seroprotection. And when you actually look at the likelihood that people are going to complete the series, the likelihood of actually developing seroprotection, at least in our institution, Hepatitis B actually ended up cheaper. So I recommend everybody go in a program RISE. Many of our clients were not completing the 3 vaccine. They never came back for that 6 month. Once we switched over to Hepatitis B, almost everybody completed it, and we have been getting hepatitis B surface antibodies to make sure, because this is such a high risk population, that they had actually achieved seroprotection. And once we started hepatitis B, we actually stopped that as well, because everybody had achieved seroprotection. And so now we didn't have a lab value. Now we had much higher rates of seroprotection, and we weren't driving everyone crazy. So again, each organization has their own sort of dynamics, but it's an exercise that's worth going through.
Absolutely, I totally agree with that. I think the long-term benefits of preventing something that's going to require a lot more surveillance and ultrasounds and lab work and possibly treatment and or transplant. You have to think about the long game in this. And, it's a little hard to sometimes convince administration that that's what's important. But, if you have the opportunity to do so, it's a much better opportunity.
Thank you so much, guys. And so I think we are just a little bit over the hour. We really appreciate the discussion. If anybody else has questions, I can leave my email in the chat. Please feel free to reach out to us. And there's one final question I think they're looking for the health department to answer, which is, we see uninsured patients. Does the county health department cover the cost of immunizing or help cover the cost of immunizing these individuals? So I'll turn it over to the immunization branch in PA to answer.
Yeah, I just saw that question and I can take that. Yes, so in Pennsylvania, the county health departments, they do cover the cost of immunizing uninsured or underinsured individuals. They do provide vaccines at no cost, and to ensure that everybody has access to necessary vaccines, so you would have to contact your local health department on the specific details. Yeah, that will be the best place to go. And based on where you are located, if you can put the information in chat, maybe we can contact you and provide you accurate information on where to go for.
Right.
Wonderful. Well, thank you so much, Dr. Rutland and Dr. Graham. We really appreciate you having you on this call today. I think we all learned so much, and we're really excited to have the resources that you guys put together as well. So thank you all for attending our webinar series. Please be on the lookout in your emails for the recordings and the answers to the questions that you asked as well. And I hope you guys have a great rest of your day.
Thank you.
Thank you.